Good evening. My name's Kenneth Gow. I'm a pediatric surgeon at Seattle Children's. I'm also the vice chair of the APSA Healthcare and Advocacy Committee. Our chair is Dr. Catherine Bass. Together, we are pleased to present to you in this APSASode 5 outstanding abstracts and discussions. The 5 papers are positioned at the crossroads of pediatric surgery and public health. As surgeons, we have studied the unique aspects of how we can physically restore children. But how they ultimately do is often dictated by factors that are out of our control, such as socioeconomic status, insurance, race, or location of residence. These aspects are often referred to as the social determinants of health, and, as our presenters will describe, are equally or sometimes even more important to the final outcomes than what we do in the operating room. Our committee is vested in bringing these issues to the members of APSA so that you may consider how our community can influence policymakers to help children live their most fulfilling lives. This first paper is presented by Dr. Bouchard and her group from Lurie Children's in Chicago. They describe the neighborhood level social determinants of health and how they are associated with acute pediatric surgical outcomes.
Hi, my name is Megan Bouchard, and I thank you for the opportunity to present our work on neighborhood-level social determinants of health are associated with acute pediatric surgical outcomes. We have no disclosures. Timely access to surgical care is critically important, as delay in diagnosis and care can lead to worse outcomes. While most existing literature explores the effects of patient-level social determinants of health on surgical outcomes, little is known about the effects of neighborhood-level characteristics. But there is now an increasing emphasis of achieving health equity and merging public health with traditional clinical care to improve patient outcomes and mitigate health risk factors. Appendicitis is the most common acute pediatric surgical condition, and complicated appendicitis may indicate a delay in definitive diagnosis and care, thus making it a great case study to evaluate the effects of neighborhood social determinants of health on pediatric surgical conditions. The Child Opportunity Index is a comprehensive measurement of 29 neighborhood characteristics known to impact children's health and is an increasingly popular tool to assess neighborhood social determinants of health. We therefore sought to examine the effect of neighborhood-level social determinants of health as measured by the COI on the odds of presenting with complicated appendicitis. Additionally, we evaluated whether neighborhood-level social determinants of health were associated with differences in unplanned post-discharge healthcare utilization. We hypothesized that children from neighborhoods with lower-level COI would have a higher probability of presenting with complicated appendicitis and unplanned healthcare utilization. We conducted a retrospective observational study to identify patients less than or equal to 18 years old diagnosed with appendicitis between 2016 to 2018 using the Pediatric Health Information System database. FIS was linked to the COI database at the zip code level. Nationally normalized COI measurements were then divided into quintiles, ranging from very low to very high opportunity. After adjusting for covariates, hierarchical logistic regression was used to model the odds of presenting with complicated appendicitis and unplanned healthcare utilization as a function of COI. A total of 67,000 patients were identified, of whom 32.2% were complicated. The majority of patients were aged 10 to 14 years old, male, non-Hispanic white, and publicly insured. Patients who were younger, female, of an ethno-racial minority, or publicly insured were more likely to present with complicated appendicitis. As you can see, after adjusting for covariates and using very high COI as the reference point, the odds of presenting with complicated appendicitis demonstrated a nearly stepwise linear increase with each lower COI level ranging from CO1, 1.1 for high COI to 1.3 for very low COI. When evaluating the adjusted odds of unplanned healthcare utilization for simple appendicitis cases, patients who were non-Hispanic Black, Hispanic, publicly insured, and aged 0 to 4 years old had increased odds of unplanned healthcare utilization. Meanwhile, for complicated appendicitis patients, no significant differences were noted based on covariates. After adjustment, there was no difference noted in the odds of unplanned healthcare utilization based on COI for either simple or complicated appendicitis patients. Based on these findings, we concluded that neighborhood social determinants of health are associated with acute pediatric surgical outcomes, as evidenced by children from lower COI neighborhoods had an increased likelihood of presenting with complicated appendicitis even after controlling for patient-level social determinants of health. This may indicate children from lower COI neighborhoods have reduced access to surgical care or experience a delay in definitive diagnosis and treatment. However, there was no observed association between neighborhood social determinants of health and unplanned healthcare utilization. This may indicate that once patients have established care with the Children's Hospital, they are connected to a pediatric resource that can support families post-discharge, regardless of the patient's neighborhood. These findings have several potential implications. First, providers should work to implement comprehensive social determinants of health screening into their patient care, ideally preoperatively with an elective procedure, though also on the inpatient side to ensure successful patient-centered discharge planning. Second, third parties can utilize these findings to develop targeted public health interventions, neighborhood investments, and reallocation of community resources, which may assist in mitigating risk factors and improving health equity amongst pediatric patients. Ultimately, in order to improve disparities in pediatric surgical conditions, it will be critical to address the upstream effects of neighborhood social determinants of health. Thank you, and I'll be happy to take any questions.
Thank you very much, Dr. Bouchard. Now, Dr. Erica Newman will discuss this paper.
Thank you so much, Dr. Bouchard. That was such a great presentation, and thank you for sharing your work. I do have a couple of questions. One is, how would you suggest pediatric surgeons begin to use the COI in daily practice?
Thanks so much for the question, Dr. Newman. As with many public health and population level studies, the findings of the study are really less applicable to daily clinical practice. Instead, these findings really can inform future policy and public health interventions to address more of the root causes of disparate neighborhood opportunity levels. In fact, third-party payers and public health organizations and hospital systems are utilizing this data right now to address neighborhood social determinants of health through targeted investments, reallocation of community resources, and improve access to care in underserved communities. Nevertheless, health providers should continue to do patient screening for social determinants of health, both in outpatient and inpatient settings, and then can refer the patients to appropriate resources when unmet needs are identified. For example, preoperatively, a surgeon could assess a patient for food insecurity, which is more prevalent in certain neighborhoods. And because this impacts both the childhood's development as well as the ability to heal postoperatively, it's definitely relevant to pediatric surgeons. And then if positive, they can reconnect them with local community resources. Regardless, addressing these health disparities is ultimately going to require addressing the upstream effects of health outcomes, which is more at the population level, as opposed to individual clinical practice. But it will require clinical buy-in to effectively screen patients and make sure they're connected with the resources they need.
It's so important, and it's really important. It's not a mindset that we're used to as pediatric surgeons. So
yeah,
I think, we're really going to have to, start thinking about some of these more upstream factors that really do affect our patient outcomes. I have another question. How accurate do you think the zip code is really as an indicator? Are there other sort of more personalized indicators that determine risk?
Thanks for the great question. Ideally, the most suitable geographic unit is the census tract, as this is smaller and it's more specific to each neighborhood. And the COI actually is provided at the census tract level for nearly all census tracts in the 50 states and DC for 2015. And it also provides the zip code level data. Given that we used FIS as our medical database, it only provides zip code level data, so we needed to instead use the COI zip codes for appropriate cross-linking between the databases. So we recognize that some zip codes may include very diverse geographic areas, and this is a potential limitation to the study. In the future, using the COI census tract data could be bridged with other databases or even institutional data, more local data that could provide specific information, but that would be something that we need to do in the future.
Mm-hmm. Well, this is certainly important work, so I hope you keep going with this. This is going to make such a huge impact for our field. Thank you, and good job.
Thank you so much.
This next paper is from Dr. Ahn and her group from Seattle Children's Hospital. They discuss the urological care in anorectal malformations.
Good evening, and thank you for the opportunity to present our work. While fecal incontinence is a concern for many children with anorectal malformations, urinary incontinence is also prevalent. Incontinence is known to be associated with anatomic factors such as ARM complexity or spine or sacral anomalies. Sociodemographic factors are widely associated with healthcare disparities, such as differences in pediatric readmissions, surgical complications, or incidences of chronic diseases such as asthma. However, to date, these types of differences have not yet been evaluated in children with ARM. Our objective was to assess urinary continence rates in children and adolescents with anorectal malformations and to evaluate associations of sociodemographic factors with urinary continence. We hypothesized that continence rates were low overall and associated with public insurance and minority groups. We performed a retrospective cohort study utilizing the PCPLC registry, a multi-center research consortium of colorectal specialty centers. We included individuals with anorectal malformations ages 3 and older. Our primary outcome was urinary continence, defined with the 4 categories seen here based on patient and clinician report. Our exposures of interest included sociodemographic variables, as well as the clinical characteristics seen here. Univariate associations were tested, and following that, a multivariable logistic regression model was created to assess the odds of urinary continence with the binary outcome, including complete, daytime, or partial versus none. The cohort was comprised of 525 subjects with a median age of 7 years. The majority were white and with private insurance, and 17% were adopted. Clinical characteristics showed an even split of complexity of ARM, and the majority had normal spines and sacrums. On univariate analysis, older age was associated with improved continence. However, almost 30% of school-age children reported poor or no continence. Having public insurance was also associated with worse continence, and being adopted trended towards decreased continence. Neither race nor ethnicity was associated with continence status. The logistic regression model included the clinical and sociodemographic exposure variables and showed that clinical factors such as more complex anorectal malformation, abnormal spine or sacrum were associated with decreased continence, while race and ethnicity were not. Adopted individuals had lower odds of urinary continence, and having public insurance also trended towards a lower odds of continence. This study represents a heterogeneous study population, and there may be selection bias as well, as many of these institutions are specialty or referral centers. Patients presenting there could be skewed towards those with more refractory disease or perhaps those with more access or means to care. The definition of continence was standardized on the data collection sheets, but was recorded based on family and clinician report rather than other objective methods. However, despite these limitations, this is the first multi-center study to evaluate urinary continence in individuals with anorectal malformations and shows that it does improve with age. However, almost a third of school-age children still reported poor continence. Our study also confirms previous findings of clinical severity correlating with worse urinary continence and also demonstrates a novel finding that being adopted and having public insurance are potential risks for worse urinary continence. Certainly more work is needed to understand the etiologies of these differences. Thank you very much.
Thank you, Dr. Ahn, for presenting your paper. Dr. Mark Levitt will now discuss.
Hello, APSA. This is Mark Levitt from Washington, D.C. Thanks for inviting me to discuss this paper. Thank you to Dr. Ahn and all of her colleagues from the PCPLC, the Pediatric, Colorectal, and Learning Consortium. Urinary continence disparities in patients with anorectal malformations is a vital topic that has been handled in this presentation. There's a high incidence of incontinence, about 1/3, and it points to the need for urology, collaboration, and good initial surgery. And of course, is noted by the fact that continence is affected by ARM type, sacrum, and spine. The main issues covered in this paper were socioeconomic factors or sociodemographic factors affecting the continence rates that were being noted: race, ethnicity, insurance. It's a vital review of 525 patients. I have 3 questions. 1, the patient group that was adopted, was reoperation considered a factor? perhaps those who were reoperated on, and for that reason alone, not the fact that they were adopted, affected their continence rate. 2, with regard to the public insurance finding, why was this? Was this because the patients had less follow-up? And 3, how did this incontinence break out when considering associated sacral and spinal anomalies as compared with those with normal sacrum and spines? Thank you so much for your contribution.
Hi, Dr. Levitt. Thank you so much for your thoughtful review and your questions. As to the first one, this study did not specifically look at why those who were adopted had lower odds of urinary continence. Now, this finding is likely multifactorial, as you point out, and the need for redo repair could certainly contribute. We found when we looked back that overall in this cohort, 16% of those repaired required a redo, and 18% of those who were adopted required a redo. So there was not a huge difference, but it's still certainly worthy of future investigation, as the adopted group may have been too small to detect a true difference. As far as looking at redo versus primary repair, we did not specifically look at this overall in the study, but certainly is something to look at in a future study using the PCPLC. As to your second question about the public insurance, again, we don't know exactly why this association was detected, but certainly is something that we would like to investigate in future studies. Now, thinking about it, it's certainly unlikely that those with public insurance have had true clinical differences with regard to ARM type or quality of their spine or sacrum. But other studies all throughout medicine certainly have shown that those with public insurance have worse outcomes in other arenas. Some possible etiologies here include differential access to care, potentially limited resources for bowel and bladder management, especially the programs that require a lot of time and supplies, or there may also be caregiver or provider bias in how we report continence outcomes in different patient populations. So certainly, now that we know that there is this association, it is important for us to go forward and evaluate more closely to understand why, and then to ensure that all kids are getting equitable care. And your third question is a great one, as prior studies have shown that those with abnormal spine or sacrum have worse urinary and fecal incontinence. Our results definitely reflected that same finding. In our cohort, those with abnormal spine or sacrum were about 45% less likely to be continent of urine on multivariate adjusted analyses. These clinical factors definitely drive a lot of the potential for urinary continence overall, but we believe it is also important to better understand the social and demographic factors at play as well. So thanks so much.
The next paper is from Dr. Hahn and his group from the Oregon Health and Science University, and they will discuss the impact of COVID pandemic on telemedicine utilization in pediatric surgery.
Hello, my name is Shayu Han. I'm a surgery resident at OHSU in Portland, Oregon. Thank you for the opportunity to share our work today. The COVID pandemic has significantly altered medical practice around the world. There's been an increased use of telemedicine during this time, and there's concern that telemedicine may widen existing inequities in healthcare, particularly in the delivery of healthcare to children. Given this, we sought to answer the following questions. Was there an increased use of telemedicine in pediatric surgery during the COVID pandemic? And what is the impact of telemedicine on children's access to pediatric surgical services? In order to answer this question, we performed a retrospective case-controlled study of a single-center tertiary referral pediatric surgery clinic. Our study period is from June 2019 to February 2021, and we recorded encounter date, visit type, visit modality, zip code, and no-show status. We use patient zip codes to estimate patients' median income based on US Census Bureau data from 2010. And we use patient zip codes also to place the patient encounter on a rural to urban spectrum using the US Department of Agriculture's 2013 Rural Urban Continuum codes. A RUC code of 1 indicates an urban setting, and a RUC code of 9 indicates a more rural setting, and there are scores between 1 and 9. We coded a total of 3,294 encounters. The chart on the left shows total number of visits over time, demonstrating relative stability in the number of visits. The chart on the right shows telemedicine utilization over time, which shows significant increase of telemedicine use during the pandemic as compared with a modest use of telemedicine before the pandemic. This summary chart compares visit type, visit modality, and no-show rates before and during the pandemic. There was no significant change in the visit type before versus during the COVID pandemic. We saw a similar number of new patients versus follow-up patients. In terms of visit modality, there's a significant shift from in-person visits to telephone and primarily video visits. In terms of no-show rates, there was a across-the-board decrease in the rate of no-show rates for both in-person and telephone and video visits. When we looked at socioeconomic status, there's no difference in the average median income before and after the pandemic. When looking at the distribution of rural to urban encounters, there's no significant difference between pre-COVID and during COVID. As you recall, lower RUC scores indicate metropolitan areas and higher RUC scores indicate a more rural setting. We looked at the use of telemedicine in these two different populations. So this chart on the left two columns show the pre and during COVID utilization of telemedicine in children in metropolitan areas, and the two columns on the right show pre and during COVID rates of telemedicine utilization in children from rural areas. And there is a greater adoption of telemedicine in children from rural areas as compared with children from metropolitan areas. In sum, there's a significant increase of telemedicine use in pediatric surgery across the board during the pandemic. Poor and rural access appears to be preserved, and this preservation appears to be mediated through the use of telemedicine. There are limitations to our study. This is a single-center retrospective study, and our proxies for social economic status and rural-urban classification are imperfect. Thank you for the opportunity to present our work. I'll take any questions.
Thank you, Dr. Hahn. Dr. Mary Phalic will now discuss.
Dr. Hahn, I really enjoyed your presentation. Oregon is a primarily rural state. And so how often did you find that your internet connectivity failed or that you had challenges with recording when you were dealing with a patient?
Dr. Phalic, thank you so much for that wonderful question. Surprisingly, we found less technical glitches that impacted our ability to provide telemedicine during the pandemic than before the pandemic. And the rates, overall rates were quite low. I think one of the more surprising findings and heartening findings of our study was that the proportion of rural patients that we saw did not change. And that seemed to be primarily mediated through their increased use of telemedicine beyond even metropolitan children. So it seemed from our perspective that telemedicine seemed to preserve care for rural children.
So I have had experiences where it's been really difficult to see something on physical exam in a wiggly child. How did you overcome your ability to do a physical exam on a child?
That's a great question as well. There are some patients that I think will always need an in-person visit. One of those patient populations would be families who elect to or volunteer to only have an in-person visit. And so for those families, we offer them in-person visits. Other patients who require a complex physical exam in order to guide their care will be seen as in-person visits as well. For instance, inguinal hernia or patients with inguinal hernia that need a detailed multi-step exam to verify kind of exam findings. Those patients will always need an in-person visit, but most exam findings can be elicited or approximated using video visits by cell phones, kind of closely showing postoperative incisions, seeing how the baby reacts when mom or dad pushes on their belly, things that, orthogonal means of estimating exam based on how the baby reacts to what we do to them.
So multidisciplinary visits are really popular now, multidisciplinary clinics. Have you tried this modality with multiple providers at once?
Not to my knowledge. We have had good handoffs between physicians and nurses within our own team in terms of, for instance, OSME teaching or preoperative instructions, handoffs virtually that way. I know of some centers that have one Zoom meeting where basically the providers rotate through patients so that patients stay in the same kind of virtual video visit and providers come in and out. That kind of reproduces the Schreiner model of patient stays in the same physical exam room, and then you have physical therapy, occupational therapy, neurology, and orthopedics kind of going through and seeing patients in their exam room. So I think that's a great patient-centric way of translating something that we already do in some centers in person to the virtual platform.
So if you decided you really needed to operate on a patient, did you do your COVID test locally and then have them come when the COVID test was negative, or did you do it on site?
That's a great question. And that depended on the availability of COVID testing in the community. If there was a lead time of greater than a couple of days in the community, then we would just have them do a rapid test day of the surgery. And so we have had a certain number of rapid COVID tests, even in the height of the pandemic, reserved for patients who are in this exact scenario where they had to travel a far distance, couldn't get a COVID test preoperatively. They would come in for rapid COVID testing the day of.
So last question is, you could envision something like a trip saver surgery where you see the patient, you bring them over and do a quick exam, confirm your findings, do the surgery, send them back, and then you have your video visit afterwards. Did you find that was something you could do?
Yeah, I think, in many ways, our telemedicine, our preoperative telemedicine consultations were very similar to this, where the caveat was always, we do our best to gather a history and physical exam virtually before meeting the patient, but reserve the right to cancel their case if there's something surprising on history or physical that we find on the day of surgery that we didn't expect. And families have been very satisfied with this, and our rates of cancellations have been incredibly low in the single digits, despite seeing hundreds, if not thousands, of patients during the pandemic.
So I really enjoyed your presentation. Again, good luck with this. And I hope your patients continue to watch your video visits and you can expand your program.
Thank you, Dr. Phalic.
The next paper will be from Dr. Gonzalez and her team from Albert Einstein. They discuss how healthy African American children who lack health insurance predicts a positive coronavirus diagnosis.
Hello, my name is Dr. Natalie Gonzalez, and I'm a pediatric resident at Albert Einstein Medical Center and the Director of Special Projects at the Black Doctors COVID-19 Consortium. Today, I will be presenting our research at the BDCC involving African American children in relation to the coronavirus pandemic, titled "In Healthy African American Children, Lack of Health Insurance Predicts a Positive Coronavirus Diagnosis." We'll begin with some background of findings in the early stages of the pandemic. Of the SARS-CoV-2 associated deaths in patients aged less than 21 years that were reported to the CDC by July 31st, 2020, about 78% of those cases were African Americans, Hispanics, and non-Hispanic Native Americans. It was noted that in the US, there seemed to be a lack of COVID testing and contact tracing among African American parents and their children. It is thought that perhaps testing locations were not appropriately equipped to test pediatric patients. And as with any outbreak, testing and contact tracing is essential in mitigating spread of the virus and decreasing morbidity and mortality. So at this time, as the pandemic worsened here in Philadelphia, the Black Doctors COVID-19 Consortium was founded by pediatric surgeon Dr. Ayla Stanford. She gathered a few healthcare professionals, from doctors to medical students, and went door to door administering the COVID tests for those who signed up for it. The BDCC was able to obtain a listing of the zip codes that were hardest hit by COVID through the Philadelphia Department of Health. The operations expanded to faith-based organizations within those affected neighborhoods where patients were tested by the hundreds, many of them pediatric patients less than 18 years old. To specifically cater to our pediatric population, at times testing sites would occur at parks and playgrounds. Testing was done at no cost to the individual being tested by using FDA-approved COVID-19 nasal and nasopharyngeal swabs. After testing, patients were contacted with their results by a qualified medical professional, and patients were provided with next steps if found to be positive. On the side here, you can see a map of Philadelphia detailing a COVID positive rates that were broken down by zip code. As you can see, the areas with highest rates were in North Philadelphia, which is an area that has a population consisting predominantly of those within the Black and Brown community. Our data used in this study was collected between April and September 2020. And during that time, we tested 403 children, and 10% of those children were found to be positive for COVID-19, with the highest positivity rates found between April and May 2020. Children aged 6 to 10 had the highest positivity rates at 12%. Children less than 6 years old were at 8%, and those aged 11 to 17 were at 9%. In our study, comorbid conditions did not prove to be significant predictors of COVID-19 positive results. More than half of the children did have health insurance. However, results indicated that those who did not have health insurance were 2.77 times more likely to be COVID positive. In conclusion, lack of health insurance is often an indicator of poverty and diminished access to quality health care. Without quality health care, children are being left more susceptible to SARS-CoV-2, and our data supports this fact. We try to combat that by providing barrier-free testing for uninsured children, and it's our job as medical professionals to advocate for our pediatric patients, work towards equity in healthcare, and abolish systemic barriers that contribute to health disparities. These are my references. And anyone that would like to get in contact with the Black Doctors COVID-19 Consortium, I've provided our information here with office number, email, website, and social media handles. And if you would like to speak to me personally, I have also provided my email. Thank you.
Thank you, Dr. Gonzalez, for that paper. Dr. Barksdale will now discuss.
Dr. Gonzalez, I would like to commend you on a cogent and compelling presentation on the work that you and your mentor, Dr. Ayla Stanford, have done, not just in fighting the scourge of SARS-CoV-19's impact in the minority community, but more importantly, your work as both advocates and activists in the realm of health equity and social justice, mobilizing, educating, and acting on behalf of our patients and our profession. COVID-19 has laid bare the systemic inequities that plague our Black and Brown communities across this country. These social determinants of health impact health outcomes, leading to disease, disability, premature death, and in my means, most importantly, despair. I have 3 questions. The first, you report here that data from April to September of 2020. Can you provide us with an update on your numbers as it relates to children since that time? What have you observed after a year being deeply embedded in the community? Specifically, how many children have you tested? What are your positivity rates? My second question, what new lessons have you learned in the past 6 months since you submitted this abstract? Has your recent data reaffirmed your earlier observations, or are there any new insights that you've gained? Have you made modifications in your strategy or your approach? My third question, you state in your presentation that it is a lack of health insurance that serves as a proxy for poverty. You further imply that this leads to a lack of access to health care. Do you then infer that universal health insurance for children would decrease the morbidity and mortality of minority children with SARS-CoV-19, since it does not appear that there were premorbid risk factors that had impact on the disease in your study? What has the BDC proposed to mitigate the systemic health effects of poverty? For example, are you promoting educational programs to improve health literacy in the community? Are you advocating in Harrisburg, the state capital, for expanded health insurance coverage for children? And are you working with parents and community groups to get children covered by CHIP? Finally, Dr. Gonzalez, Dr. Stanford, the BDC, I commend you. You both enable us and ennoble us as pediatric surgeons in your roles as the important vanguards of children's health and purveyors of hope. Thank you for your vision, and thank you for your service.
Thank you, Dr. Barksdale, for your excellent questions. I'd like to start off with the first one concerning our updated data from September to March. In this first graph, in September to December 2020, we've broken down the pediatric population that we were able to test for COVID-19 by each month. And you can see that it's steadily climbing all the way up through to December. However, when we get to January, you see a slight decrease and then a markedly decrease in February and in March. For our insurance responses, in which we asked parents, did the child have insurance or did not have insurance? While it seems like there is a high population that did have insurance, we're going to focus on those who did not have insurance, as you see here reflected in our September to December graph, as well as our January to March graph. And the reason why we're focusing on those is because those are the individuals, those without insurance, that had the highest positivity rates for COVID-19. Now, of note, before I move forward, we were able to test an additional 1,140 children in this time frame between September to March. Now, concerning the positivity rates, you'll see here in the light green line, the children positivity rates were always hovering slightly above the adult positivity rates all the way up until you get to February, where you see it goes all the way down to 0%. You see that it starts to steadily climb up through to March, because that's around the time that the country starts reopening itself. Some children are going back to school, parents are definitely going back to work, therefore transmission rates have increased. Now, steering away from the slides, I'm going to go back to your questions. So for question 2, what are the new lessons that we've learned in the past 6 months? Well, one of them is that with hybrid and in-school settings, the junior high and senior high school students tended to have higher positivity rates and outbreaks than the elementary school students. And also another lesson we learned is that one positive adult will infect the entire household of children. So it's something to keep in mind, especially when you're testing and trying to decrease the transmission of coronavirus. Now, the good thing is that our recent data just further reaffirms our earlier observations in that, yes, the insurance status correlates with high positivity rates. Now, are there any modifications to our strategy or approach? The short answer is no, but the reason is this. The Black Doctors COVID-19 Consortium has been built always on 3 main tenets: empathy, action, and access. And for this presentation, we're going to focus on access. And access being that we provided testing and now vaccination locations in the Black and brown neighborhoods highly affected by COVID-19 in Philadelphia. Along with making it more accessible to our patients, we also tried to make sure we worked later hours and had weekend availability. And we only tested not just the children, but the family themselves. So knowing their status as a family, they were able to isolate and diminish the spread amongst each other and also reduce interaction with the public, which thereby then reduced the transmission rates of COVID-19 amongst the population and allowed for early detection for supportive management of the disease. Now, moving on to your third question, I want to start off by saying this. Insurance is just insurance. It does not provide access in and of itself. The healthcare institution does that. However, all too often, those without insurance or those that are being underinsured are the last to be scheduled for appointments. And in Philadelphia, for children, they are predetermined to only be cared for by one children's hospital based on the insurance that they have. Now, does this mean that we should move toward a universal health insurance in order to decrease morbidity and mortality? My short answer is no. And the reason being is that oftentimes public assistance and suboptimal insurance grants you delayed entry or only entry to certain healthcare institutions. So this doesn't really change things by much in terms of the quality of care, because those specific healthcare institutions are usually short-staffed with limited resources, and they're in unsafe neighborhoods. So ultimately the question is what is the BDCC doing about this to create systemic change? Well, first, change comes with the caregiver themselves. But unfortunately, now access, care, resources, time spent with the patient, and even in some cases, empathy is dictated by the type of insurance a person has. We continue to work with academic institutions and the health department, sharing our data, striving towards equity and policy change. Additionally, the Black Doctors COVID-19 Consortium is opening a multidisciplinary clinic in Northern Philadelphia at year's end to address these needs. As we have been a constant presence in the community, many began to come to our testing and vaccination sites for primary care advice. More immediately, we have already initiated an appointment portal for all of the children of the adults that we have vaccinated, which is over 43,000 to date, as we anticipate the EUA for Pfizer use in 12 to 15-year-olds will be approved this summer. Our goal is to vaccinate with both shots 10,000 children, 10% of the city's population of 12 to 15-year-olds, 2 weeks before it begins. As we know, though the deaths from COVID-19 in children are not as significant as adults, according to the CDC, the over 75% of children who do die of COVID are children of color, the majority of those being African-American children. So as with the adults, we will continue to serve those most vulnerable and impacted from coronavirus disease. Again, I'd like to thank you, Dr. Barksdale, for your thought-provoking questions.
The next paper is from Dr. Mead and her group from Le Bonheur Children's Hospital. They look at the adverse childhood experiences in pediatric trauma population, an evaluation of an at-risk population.
Hi, my name is Regan Mead, and I'm a third-year medical student at the University of Tennessee Health Science Center College of Medicine. Today, we will be discussing adverse childhood experiences, or ACEs, in the pediatric trauma population, evaluation of an at-risk population. I have no disclosures to report at this time. Shelby County in Memphis, Tennessee reported 408 violent crimes encompassing 577 offenses in 2019. Nearly 40 children were victims of homicide in 2020, making up 10% of all homicides, most of which were due to gun violence. This graph depicts almost 30% of victims with reported ages in violent crimes in Shelby County were part of the pediatric population. This study focused on adverse childhood experiences, or ACEs, which encompass stressful and traumatic events occurring before 18 years of age. ACEs increase long-term adverse health outcomes, some of which are listed in red. In the US, approximately 10% of children experience greater than or equal to 3 ACEs. Arkansas leads the country with at least 56% of children experiencing at least 1 ACE, while 46% of children in Tennessee and 51% of children in Mississippi experience at least 1 ACE. Le Bonheur Children's Hospital regularly treats children from all 3 of these states. ACEs are highest among African American and Hispanic children. The most important predictive factors for ACE exposure were family structure, poverty or income level, health insurance status, special healthcare needs status, and the child's age. Brown et al. Found that those with 6 or more ACEs lived on average 20 years less than those without ACEs. Currently, there is no literature examining the incidence of ACEs in the pediatric trauma population, especially in the clinical setting following a trauma. We hypothesize pediatric trauma patients present with increased ACEs and may serve as initial point of intervention for a previously unreached at-risk population. We used Pearl's tool for all patients presenting to the trauma clinic from September of 2019 to December of 2020. The study was extended from July of 2020 to December of 2020 due to COVID interruption. The data in this presentation is reflective of that collected through July of 2020. The criteria for a positive test are outlined in red. Screening tests were given to caregivers for all children, while patients aged 13 or older were given the opportunity to fill out their own screening test as well. An example of the Pearls tool provided by the Center for Youth Wellness can be seen here. Greater than or equal to 2 ACEs for ages 0 to 12 are considered a positive screen, and 4 ACEs indicate a positive screen for the age range of 13 to 18. The study had majority male and African American participants. Public insurance status predominated. Most traumas consisted of blunt or burn trauma. In conclusion, greater than 25% of patients presenting to the pediatric trauma clinic reported a high prevalence of ACEs exposure. Of note, nearly 50% of teenage patients reported high prevalence, often more than their caregivers reported. The trauma clinic provides the initial point of screening and potential intervention with an opportunity to offer social and psychological support for this at-risk population. We recently received grant funding from the Urban Child Institute to provide dedicated mental health resources within the trauma department and are utilizing partnerships to provide inpatient and outpatient evaluation and treatment options. Hopefully, this can be further integrated into community programs and schools. Special thanks to all of our colleagues and everyone who worked so hard to make this research possible. Our references are listed here, and here is some contact information. Thank you so much for your time.
Dr. Tony Escobar will now discuss.
Hi, my name is Tony Escobar, and I'm a pediatric surgeon at Mary Bridge Children's Hospital in Tacoma, Washington. I'd like to thank Drs. Bass and Gao and Ms. Mead and Dr. Williams for inviting me to discuss this excellent abstract entitled Adverse Childhood Experiences in the Pediatric Trauma Population, Evaluation of an At-Risk Population. Regan, thank you for joining me today.
Thank you.
As Ms. Mead and her co-authors stress, ACEs are associated with physiological, psychological, and social ramifications that impact the lifetime of a child. While there are clear association of ACEs to abuse, violence, and bullying, trauma is not as well studied as the authors highlight. The American Academy of Pediatrics has recognized the impact of ACEs in the health and well-being of children in the last several years. In fact, they have launched the Resiliency Project in an attempt to combat toxic stress. I applaud the authors' work to screen for ACEs in this overlooked population. However, it can be difficult to justify the resources that are needed to fully embrace and impact ACEs. There's no tangible benefit like $1 earned on an operation or an admission to the hospital. The challenge for many programs is to find support. And in this day and age of program cuts and loss of ancillary services, how do we advocate for these resources, especially when the effects of the work may never be seen, as our goal is to actually prevent future healthcare resource utilization? Thank you, Regan.
Yes, thank you. So speaking to some of the questions that you pose with the financial state and getting funding and sort of down that vein, we have the main purpose of the study was to show that there is a need and this is a point of intervention. And we were able to show that. And now we were able to get some state funding that allowed us to sort of divert a lot of our patients towards the Brain Center with Dr. Irena Schaus to receive some free mental health counseling. And as we see the benefits and continue to follow those benefits of that counseling, we have determined that we will be able to bill for that service. So that is, that's a point where we're hoping to get sort of a different utilization of services, but still seek some benefit from that, both for the hospital and for the patient. But as Dr. Williams would like to state, and her and I sort of spoke about this as well, as a children's hospital, one of Le Bonheur's primary goals, as I would expect is similar for most other children's hospitals, is community outreach and improving the overall well-being of our patient population. And if that necessitates some financial differences in the future, then that's something that we're willing to accept, because the benefits from this will hopefully outweigh the problems that would pose.
So really, you're investing in your community in the future, and the return on investment is the future health of our children.
Yes.
Which could be no higher, return.
Exactly. And hopefully that'll decrease some of the sort of unnecessary health expenditures on these other adverse outcomes that we see in children who have these excessive ACEs exposures. And then we can focus more on more patient care on more specific problems and help prevent issues like obesity and pediatric obesity and things like that.
shifting the focus outside of the hospital more to the medical home and overall decreasing cost for healthcare. I mean, this is fantastic. So Regan, thank you very much. I very much enjoyed your presentation, and we'll turn it back over to the Advocacy Committee. Thank you.
Thank you so much.
Thanks to all who were able to join us on this APSASode. We would also like to thank the presenters as well as our discussants for doing an outstanding job in bringing these really important topics to light. We truly feel from our committee that these presentations will help set the stage for improving the care of children in the future. And along those lines, I ask you to look out for our other APSASode that is coming up on gun violence. I, Kenneth Gow, and my chair of our advocacy committee, Dr. Catherine Bass, thank you and wish you a good night.